So this subset is characterized by amplification of the gene HER2. Now this amplification is seen very commonly in breast cancer and gastric cancer, and actually there are drugs that can target this gene. So our interest in this subset of colon cancer, of course, it stems from the fact that you have potentially really active drugs that can target this subset. So we looked at our group of patients in which patients had HER2 amplifications, and then there were others that didn't have HER2 amplifications, and what we tried to do is try to see the difference between these two. Now, preclinically, we know that these patients who have this gene amplification, they are resistant to anti-EGFR monoclonal antibodies, specifically cetuximab and panitumumab, which are currently the standard of care in colon cancer. When you have this gene, these patients don't respond. So when we looked at our group, we took patients who had received these anti-EGFR monoclonal antibodies with chemotherapy, and we found that the HER2 amplified patients did not respond at all. In fact, the progression-free survival in this group was less than 3 months compared to 8 to 9 months in patients who were not HER2 amplified. So we strongly believe that this is a negative predictive biomarker for anti-EGFR chemotherapy, which is very interesting because if you can do this testing routinely in your patients who are RAS wild type, you can save giving them a highly toxic standard of care, which doesn't work. And you can identify them for early enrollment to clinical trials with drugs that can target this gene, one of which is the SWOG 1613 trial, which is going to be a national trial, which we are in the process of launching, which would take all these patients and randomize them to giving them dual anti-HER2 therapy with trastuzumab and pertuzumab, which is a fairly well-tolerated regimen, against cetuximab irinotecan, which would be the current standard of care.